All righty, we are ready to get going with special challenges. Since I'm a special challenge patient today, I'll be doing limited walking around. Huh? All right. What are we gonna learn about today? First thing we're gonna learn about is no matter how bad things get, your patient always deserves above and beyond the best care on every call. I would hope that's what you expect for yourself, for your loved ones. Always be the EMT you want to be, you would want your patient. Always be the EMT you would want if you were the patient. That's what I meant to say. So, a lot of stuff happened yesterday. I don't know about your personal life, but I'm sure something happened. So stuff happens every day. Doesn't matter what happened yesterday. It's what you do today. It's what you do after something happens. So make sure you use yesterday as a positive building block for today or tomorrow. If you're doing something you truly care about, truly believe in, you should always be giving 200% to it. Any questions? We had a lot of questions about observation time and ride along time and about doing the bare minimum. Never do the bare minimum. Any questions? So what are we learning about tonight? We're going to learn about developmental my goodness. Developmental disabilities. Sound like the president. Sensory disabilities, physical disabilities, bariatric patients, all kinds of medical tech out there. People used to have to live in hospitals and nursing homes, now live at home because of pretty amazing medical technology. Hospice and dealing with poverty and the homeless. Bless you. Does anyone have any questions about the objectives of what we're going to learn tonight? All right. Developmental disabilities. You're going to see a broad spectrum of them. These patients have a high patient load. Autism. Autism is a very poorly understood impairment of social interaction. Everybody has a theory about autism. No one has any scientific definition or proof of what it is, how to treat it. There's been some successful treatments. There's been a lot of unsuccessful treatments. I can tell you one thing. My personal experience with autism, I have quite a bit. We used to have a home for the autistic in Mount Shasta. We used to get 911s there all the time. A lot of autistic kids also have seizures. I don't know what the correlation is. I have no idea. But they will not acknowledge you. They won't even acknowledge your existence. Do not try to touch them. You will have a fight on your hands with most autistic kids if you try to touch them. They will have a gaze off in a different direction and not even acknowledge your existence. But if you say, call them, ask them by name and ask them to do something, they will usually do it. So, you know, if the kid's name's Bartholomew, you say, Bartholomew, you please walk over to the gurney. They won't even acknowledge you. They'll just walk over to the gurney. They hear you. They know what's going on. They have a very, there's a blockade for them on social interaction. Any questions? Down syndrome. Down syndrome is a chromosomal defect. Also usually has cardiac association with it, cardiac issues. A lot of Down syndrome people don't live very long. They live until their early 20s, early 30s. Some live till they're older. Basically, it comes down to how severe the defect is and how much help they get in education along the way. There's some people that never develop at all, and there's some people that can actually live completely independent lives with Down syndrome. Any questions? Then TBI, you've heard a lot about TBI in this class. Traumatic brain injury. Again, that also can go from very mild to extremely severe, completely loss of cognitive function. Any questions? No questions. Blind people. Got a group of blind people over here. They did a great job. Those and those. Put up the blinds.
Oh,
So one of the common mistakes I see in EMS and fire is when someone's blind, they think they're also deaf. So when they find out they're blind, they immediately start talking louder to them. I'm Brian, I'm with the ambulance. Can you hear me? And they'll always tell you, yes, I'm blind, I'm not deaf. Matter of fact, their hearing is actually better than most. They pick up on things that most of us normally wouldn't. Don't yell at them. Just do a patient assessment, treat them like everybody else. Any questions? Now, deaf people actually can't hear. And no matter how much you yell at them, they're still not going to hear you. Just like with a different language, you can talk it louder and slower, they're not going to understand English better. But yeah, we try. With hearing, usually use, if you know sign language, that'd be the best. Very few people know. How many people here know ASL? One. Yeah.
I see two.
Two? Where's the other one? Oh, I'm sorry. I didn't see over there. I didn't look to the right. I wasn't doing my autistic. Anyway. Pen and paper, if you don't know ASL, if you know ASL, that's amazing and huge in these patients. If you don't know ASL, writing down notepad, computer, things like that, it's going to be your best way to communicate. Any questions? All right, cerebral palsy is another disorder that is very, very varying in levels. It could be from very mild to very severe. Also, for some reason, people mistake the motor function, the poorly controlled motor function, to also be cognitive issues. Cerebral palsy people have no cognitive issues. They're completely 100% aware of what's going on and intelligent. It has nothing to do with their intellectual capabilities. It's strictly motor and spasmodic movement. And here's a video on it, and I'll tell you much more about it than I will. And it also won't stutter and slur speech. Maybe.
Cerebral palsy is an umbrella term for a group of disorders that affects a person's ability to move. This means that not everyone with cerebral palsy looks the same. There is a meaningful future for every child, adolescent, and adult living with cerebral palsy. For every person, there is a positive way forward through treatment and support provided in partnership with individuals and their families. Cerebral palsy is caused by an injury to the brain that usually happens during pregnancy, but sometimes it may happen shortly after birth. Cerebral palsy affects people in different ways because different parts of the brain can be injured. However, it always has some impact on the person's movements, and this is because the messages coming from the brain to the muscles are affected. Cerebral palsy is the most common physical disability in childhood, with 1 in 500 children born in Australia each year. Cerebral palsy affects people in different ways, and this is largely due to the location of the injury in the brain. Therefore, cerebral palsy is described in a number of ways, including the parts of the body affected and the way in which it affects movement. Where the whole body is affected, that is, both arms and legs and the trunk, this is called quadriplegia. Where both legs are mainly affected, this is called diplegia. People with diplegia often also have difficulties with fine movements of their hands. When one side of the body is affected, for example, the left arm and the left leg, this is called hemiplegia. The next way of describing cerebral palsy is to talk about the way it affects movement and the type of movement difficulties experienced by people with cerebral palsy. Spasticity is probably the most commonly known term. Spasticity is present in about 86% of people with cerebral palsy. It results in muscles that become stiff and tight, which can make it difficult for someone with spasticity to use their muscles easily. It is difficult for someone with spasticity to turn their muscles on and off when they want to. This makes it difficult for them to move their arm or leg to do a task, or to use their mouth and face muscles to eat and talk. Some people have a little bit of spasticity, other people have a lot. The impact of spasticity on movement will therefore vary enormously between individuals. You might also have heard the terms dystonia or athetosis. Dystonia and athetosis describe movements seen in dyskinetic forms of cerebral palsy. Dyskinetic or dyskinesia refers to movements that are involuntary. These involuntary movements can become more noticeable when a person tries to move or when they become excited, agitated, or tired. Dystonia results in unusual twisting postures, repetitive movements, or sometimes both. Dystonia can present in one part of the body, such as an arm or foot, or throughout the whole body. With athetosis, we see slow, continuous, involuntary writhing movements that are present at rest and made worse by attempts to move. Around 6% of people with cerebral palsy have dyskinesia, with dystonia more common than athetosis. One of the less common forms of cerebral palsy is ataxia. Ataxia means without order or incoordination. Ataxic movements are characterized by clumsiness, imprecision, or instability. Movements are not smooth and may appear disorganized or jerky. The incoordination seen with ataxia occurs when a person attempts to perform voluntary movements, such as walking or picking up objects. Ataxia causes an interruption of muscle control in the arms and legs, resulting in a lack of balance and coordination. Sometimes people have a mixed type of cerebral palsy. For example, some people have both spasticity and dystonia.
Spina bifida is a very unfortunate situation where the cord is protruding from the back at birth. It's also repairable. They can actually do in uterine repair sometimes.
Neural tube defects are usually picked up on ultrasound during pregnancy checkups or antenatal checkups. Now, neural tube defects are abnormalities that occur in the brain, spine, and spinal column during embryonic development and which are present at birth. It's important to remember that not only the brain and spine are involved, but also the bones are involved, the bones that protect the central nervous system. Neural tube defects can be classified into different types. One example is spina bifida, which is the most common type of neural tube defect. It occurs when the neural tube does not close completely. It can present as an open defect with a sac coming out, or it can be closed. Anencephaly is a more severe but less common type of neural tube defect. This condition occurs when the neural tube fails to close at the top. The fetus has little or no brain matter and also may be lacking part of the skull. Now let's look back at embryology to understand how this defect happens. At about day 21, or week 3 of embryology, this is where neurulation comes in. This is when the neural tube forms and then closes. So here, the neural folds are fusing, forming what we call the neural tube.
What do smart chiropractors and doctors do when they get joint pain? See, the second us chiropractors feel joint pain coming on, whether it's in our knees, lower back, wrists, you name it, we don't lay on a buddy's table and get realigned, nor do I recommend it to you.
The neural
I'm a little
tube will
spaced out if you didn't notice.
essentially form the brain.
I thought you were just watching the ad.
Cord and how the spinal column.
Thank you for the help.
And there's actually a sequence of neural tube folding, fusion of neural tube.
So here's your Halloween trivia question. Everybody see the original Pet Cemetery? Pet Cemetery? What did doctor's wife's sister have? Remember the flashbacks? They left her alone and she died?
Yes.
What was it? Spina bifida.
Usually begins with 9. 1, 2, 3, 4, 5.
Yeah.
This edge.
The
of
entire
neural
spine's
tube
up,
is
so
older
what this really
than
is.
the lower part of the spine. And here is the cranial end, the head is to say. So this can be represented on the baby. Remember, fusion of the neural tube, the central
Wish I could
nervous
draw
system,
like
the
this.
spinal column, begins
Really
usually
good.
in the middle, midline. So here is 1, 2, 3, 4, 5. This being the caudal, the lower part, and the cranial, the brain basically. So keep this embryology in mind, which happens again at week 3 to 4. And there's essentially 2 outcomes. First outcome is that there's fusion. There's a complete fusion of the neural tube. And in all segments, everything is normal. Or there can be failure of certain segments of the neural tube folding. And this will result in problems. Here, the caudal part or the head part of the neural tube did not fold properly, resulting in anencephaly, where you have loss of the brain and possibly part of the skull that protects it. In spina bifida, which is the most common type of neural tube defect, it is usually the midline or bottom part of the tube that is not fused properly, causing either a closed or open spina bifida, depending how bad the fusion of the neural tube is. There is a severe form of neural tube defect where all segments of the neural tube does not fuse during weeks 3 to 4, resulting in a fetus with open, missing brain and spinal cord, unprotected by skull and the vertebrae. This rare form of neural tube defect, which I'm probably not going to pronounce correctly, is craniovegetis, which again is a result from failure of the neural tube closure over the entire body axis. Because spina bifida is the most common type of neural tube defect, let's learn a bit more about it. Spina bifida can be further classified based on a few things. But first, let's just recap some anatomy. Here we are looking at the sagittal section of the back. So here is the skin of our back. Here is the vertebral body, the vertebral spinous process, and it covers the meninges. The meninges essentially protect the cerebral spinal fluid and the spinal cord. Now, remember, the neural tube actually will help form the spinal cord. Spina bifida is classified as the process, as well. Spina bifida is open when the defect is exposed to the environment, or is closed when the defect is covered with skin. Spina bifida occulta is the mildest form, and most experts do not consider it to be a true neural tube defect. Spina bifida occulta is covered by skin and looks normal, so it's a closed spina bifida. There is a small gap in the spine, but no opening or sac on the back. The nerves and the spinal cord are not damaged, and the defect usually does not cause any disability. There's also other closed neural tube defects, and it can be caused by malformation of fat, bone, or the membrane. In some people, it causes few or no symptoms, but other people might experience partial paralysis or other symptoms. Some babies may have a sign of a dimple or tuft of hair on the spine. In the bulge, there can be fat growing in it too. This is termed a lipoma. Meningocele is another type of spina bifida and includes a sac of fluid that protrudes through an opening in the back, but the spinal cord is not involved. Some people will have no symptoms, and some people will have more severe problems. Here we have the sac protruding, carrying the meninges, and so it will contain cerebrospinal fluid in it. Myelomeningocele is the most severe and also the most common form of spina bifida. In this condition, the bones of the spinal column do not form completely, which causes some of the spinal cord and the meninges covering the spinal cord to bulge out of the opening. So in this form of open spina bifida, you can see the spinal cord entering the bulge, and it is not covered by skin. A person with this condition usually has partial or complete paralysis in parts of the body below the spinal column. Now, bowel and urinary dysfunction are common. If you want to learn more about spinal bifida and the different types, Osmosis does a great video on it with a different take. Check them out by clicking on the link. Investigations, particularly diagnosis for spinal bifida, is usually done during the antenatal period before the fetus is born. This includes an antenatal ultrasound during weeks
That's what they
18
could
to
do
20.
before they're born and actually fix it.
Fetal serology can also be performed looking at alpha fetoprotein, beta HCG, and UE3. A fetal MRI can also be done to look for any obvious changes. After birth, it is important to check urinary tract function, and this can be done using ultrasound, EUC for blood test, as well as voiding cystourethral and urogynec studies. And this is because urinary problems or bladder problems is a very common feature in neurotube. Finally, with certain types of neurotube defects, in particular spinal bifida, it is important to check for hydrocephalus involvement, and this can be done using a CT scan and ultrasound of the head. As can be expected, neurotube defects such as spinal bifida comes with many complications, both acute and long-term. Complications after birth for the baby include hydrocephalus, neurogenic bladder, and orthopedic deformity. Long-term complications include ADHD, learning disability, weight gain, obesity, cardiovascular disease, fecal incontinence, and constipation. Urinary tract problems long-term include hydronephrosis, usually due to vesico-ureteric reflux.
That's gonna be on the test.
People can also thus have a lot of UTIs.
Just kidding.
Long-term complications also include sexual dysfunction and lymphedema.
Everybody's kind of like,
Management
too
involves
much info
management when
overload.
complications are identified at birth, as well as management in the long term. Managing hydrocephalus includes a shunt insertion, as well as antibiotic therapy. Surgical repair can help correct orthopedic and neurogenic bladder problems.
So have you ever had a patient that slips through that and has had complications that you
I have not.
see?
C for cemetery.
Not for the movie. Spelled like a kid would spell it. You ever notice that? Look at that.
I guess I never did notice that.
I figured Steve King.
It's easy to stay cozy and save energy with just a tap on your
You
voice.
guys only thought Stephen King was known for school shootings.
My sister said in that bedroom, do you see?
My sister died in the back bedroom, and that's what she was. The dirty secret. I had to. Sometimes I hated it.
That looks nothing like a spina bifida patient.
I wish she did. It wasn't just so she wouldn't feel any more pain. It was so we wouldn't feel any more pain. It was because she started to look like this monster.
It's not what spina bifida looks like. But it is Halloween. Engaged will not become one of the first paramedics. Watch show emergency. All right, paralysis, usually, hemiplegics is usually from, stroke, but it can also be from trauma. Bariatrics, these are becoming more and more prevalent every day. Require special equipment, bariatric gurneys, bariatric teams, bariatric ambulances. These are people that outweigh the equipment that we have. So it's good to get, this is where you need additional resources also. You might need 8 to 10 people to help lift or drag. What's that?
I've seen some on TV where it needs support.
Yeah. Yeah, we had one a long time ago. No one knew how much he weighed because Fairchild didn't have the ability to weigh him. He was bigger than any of their scales. So what we did was they had to take him to UC Davis. He was going to die. And we had to take him to Davis. This is before bariatric surgeries even existed. So what they did was Davis also didn't have the ability to weigh up. The scales hadn't been developed yet. So so my boss said, we can weigh him for you. They said, no, you can't. He said, yeah, trust me, we can get a weight for you. It'll be an accurate weight to the pound. So
Paddle scale.
no. So yeah, basically. So what we did was we took the gurney out and we took the horns out. So we were just gonna put on the floor pillows and stuff. And put all the pillows and linens in the ambulance. And we filled the ambulance with bread. And we drove to Sousa Ready Mix and we got a full weight on it. And then we went to Wairika, we picked them up, stopped in, filled the tank, and did the exact same route to Sousa's, weighed it again, then subtracted the difference, got his weight. And he was 875 pounds. Yeah. Yeah, well, it took him Wairika to do was he was on a hospital bed. They had a bariatric hospital bed. We didn't have a bariatric unit or gurneys. There wasn't any in the North State, that not even Sacramento. So like I said, we just cleared everything out of the ambulance, took the horns out, the gurney out, and then took a hospital out. We used 12 Wairika City firefighters, lifted him on a cart, and then moved him into the ambulance. That's what we did. Yeah. Any questions? A lot of these bariatric units, like we have them here, but they're all manual. They actually have some with winches inside the ambulance. So the entire ambulance is just for bariatrics. But even in the busiest of cities, they don't staff bariatric ambulances. They're generally waiting, so someone has to take an ambulance out of service, and that crew has to go staff the bariatric ambulance. So nothing happens fast with this. Any questions on bariatrics? Bariatrics also leads into a whole bunch of other medical problems. Lots of medical problems, heart attack, stroke, orthopedic injuries, etc. Any questions? All right, tracheostomy tubes. Here's something we hope you'll really like.
When a tracheostomy tube is introduced, the functions of the airway can be dramatically changed. Some tracheostomy tubes have a cuff to assure that all air moves in and out through the tracheostomy tube during mechanical ventilation. Proper cuff inflation should be maintained at all times. Overinflation of the cuff can cause many complications, including necrosis and trauma to the delicate tracheal tissues, as well as esophageal impingement with possible swallowing difficulty and reflux. Proper cuff inflation is best achieved by measuring the pressure in the cuff with a manometer. Even with proper cuff inflation, complications arise when airflow bypasses the upper airway, mouth, and nose. Normal sensation and airway pressures are lost. As a result, tracheostomized patients have diminished or absent functions of the aerodigestive tract. Absence of airflow through the vocal folds leaves patients without the ability to speak, causing significant frustration, anxiety, and distress. For children, losing the ability to use their voice during the critical early years of development can lead to significant speech and language delays. Patients with tracheostomies also have reduced senses of smell and taste, which can lead to poor appetite and compromise nutritional status, sometimes requiring supplemental feeding through a nasogastric or PEG tube. In addition, many of these patients have difficulty swallowing and aspirate. The cuffed tracheostomy tube may anchor the larynx, interfering with laryngeal elevation, epiglottis inversion, and airway protection. Because air escapes through the tracheostomy tube when the vocal folds close, positive subglottic pressures cannot be generated during swallowing. Reduced sensation in the larynx and pharynx leads to pooling of material in the airway and also reduces the protective cough reflex, which is necessary to clear the larynx and trachea when penetration and aspiration occur. When patients are unable to breathe through their nose, they are unable to filter, warm, and humidify the air. This has an impact on the quantity and quality of their secretions. Because patients cannot sense these secretions and generate the necessary pressures to cough, secretions accumulate in the airways, requiring suctioning by a caregiver and increased risk of trauma and infections. An open tracheostomy tube does not allow a patient to generate positive end expiratory pressure or physiologic PEEP. Without PEEP, the alveoli, which are the sacs of air in the lungs through which gases are exchanged, can collapse, causing atelectasis. Significant atelectasis results in decreased ventilation and oxygenation.
Any questions about tracheostomies? That is Carrie Hutchins. Unfortunately, she didn't get her lung transplant. We won't watch all this, but she gives an insight of living life on a ventilator. She had a severe condition called cystic fibrosis, which generally you don't make it to 30. She actually lived long enough to have 2 children, and she's been dead for a long time. This is like 20 years ago. She did some video blogs that were really good about.
Grew up in Sparta. With my family, I was diagnosed with cystic fibrosis. Basically, when I was a little tiny baby, and I was sick more when I was younger, and then more and more as I got older, being in the hospital and for lung infections and different things. And but generally lived kind of a somewhat normal life, and my family was supportive and took me to all my doctor appointments and everything else. But as the cystic fibrosis does to everybody, I know very sick after having my 2 children, which when I was young and my parents had me, I'm sure they never guessed I would even have children, that I would even live to be old enough to have children. But I have 2 wonderful boys. One is 4 years old and one is 13 years old. And that inspired me as I struggle against this disease and to the point of needing organ transplant for my lungs. So needing 2 new lungs. And so I've got to that point of knowing that without that, then I probably wouldn't see them grow up, especially my younger one. After I had him and was thinking about organ transplant, I thought, I looked in that little face and I thought, how could I not do all I can to live to see him grow up? And the only real way for me to do that is through the miracle of organ transplant. And so that's where I am today, and I'm waiting in a hospital now. I've waited for 2 years and like 9 months, but who's counting? I probably can tell you the number of days and stuff like that sometimes, but not today. But I've waited in the hospital for exactly 70 days because I've gotten too sick to be at home, and I have to be on a ventilator 24 hours a day, so I can't breathe on my own. So I have to be until I would like to say to those of you at Gift of Life that are working hard, that moves lives and work is to give people more days of their life and to give them life beyond what my body as it would be people have. And I can't say enough really about how humbled I am that other people who've never known me don't have any, I mean, really way of, being involved in my life other than, just that you have passion for organ donation, transplant. And, it's really humbling and honoring that you would work hard and come to work every day and go through probably a lot of ups and downs with it and frustrations or, of things don't work out or whatever.
Well, she made it to 33, which is pretty
Yeah.
good for cystic fibrosis.
It's really,
So apnea monitors, remember we talked about ALTE? No? ALTE, apparent life-threatening event, kids just stop breathing on their own.
Right.
Yeah,
Do you know if she ever got the transplant?
she did not. She died shortly matter of fact, she died not long after this vlog. She was 33 years old. Yeah, she died waiting. But anyway, those kids generally will quit breathing again. And that's why they've developed apnea monitors that work pretty well. When the monitor detects the patient's not breathing, it sets off a decibel alarm that is so high of decibels no one could possibly sleep through it. Got it, brother Vince, when they exhale, switch doesn't get contact for like 30 seconds, the alarm goes off. Definitely good, stimulate the baby takes a breath. I'll get it again. Kids look a little cyanotic, I don't know. I think I'd be bagging that kid. All right, internal cardiac pacemakers and defibrillators. So when the SA node's not working or that section of the right atrium is died and there is no more SA node, your hearts can only, the AV junction only sets the beat at about 40 to 60, and the ventricles only go about 40 beats a minute. So you need someone to go in there and take the place of the SA node. So you could actually put an implantable pacemaker in there. And then when the intercooled thing is people that have ventricular arrhythmias, they can also do a pacemaker defibrillator. We'll actually run a wire down, and it's an internal defibrillator, so their body will shock them if they go into VFib. And it will pace them when their heart rate gets too slow, it'll just start pacing on its own. Pretty cool stuff.
Implantable pacemakers and defibrillators are devices that apply electric shocks to maintain the rhythm of the heart and, if necessary, restart it. As the technology improves and the list of treatable conditions grows, the number of devices being implanted is increasing steadily and now exceeds 500,000 a year. The heart is made up of 4 chambers, 2 atria and 2 ventricles. On each side, the atrium is connected to the ventricle by a one-way valve. Blood is pumped as these chambers contract and relax in turn. The beating of a healthy heart is regulated by electrical impulses. The sequence begins as the atria fill with deoxygenated blood from the body on the right and oxygenated blood from the lungs on the left. An electrical signal from the sinoatrial node then causes the atria to contract, forcing blood into the ventricles. The electrical signal is then picked up by the atrioventricular node and directed into the Purkinje fibers in the ventricle walls, causing the ventricles to contract. And the blood is then pumped through the pulmonary valve on the right to the lungs and the aortic valve on the left to the rest of the body. These valves close and the cycle then restarts. When the sinoatrial node fails to function correctly, an artificial pacemaker can be fitted to help regulate the heartbeat with small, evenly timed electric shocks. This involves implanting electrodes into one or more of the heart's chambers by inserting leads into a vein near the collarbone and implanting a device called the generator just under the skin. For more severe heart conditions, an implantable defibrillator, or ICD, can be used, which is also capable of sensing a stopped heart and delivering an electric shock powerful enough to restart it. For some conditions, an even more sophisticated device, called a CRT ICD, can be implanted. This uses a third lead inserted into the left ventricle to resynchronize the ventricles when necessary. However, all these leads can cause problems of their own. Patients with ICDs have a 20% chance of a lead failure within 10 years, and replacing leads can require open heart surgery in about 2% of cases. This has resulted in several efforts to develop new pacemakers that do not depend on leads inside the heart. One design, the subcutaneous ICD, places the lead just outside the heart under the patient's skin. And wireless designs are now being developed that may eventually do away with the need for leads altogether.
Pretty cool. Any questions?
Mister, what's that video called?
What's that?
What's the video?
One more time.
What's the video called?
How pacemakers work. Yeah, the implantable defibrillator is a shocking video. It took away the left ventricular assist device. All right, so let's talk about this before we get into the video. So I messed with you guys a lot, I tell you a lot of stuff that's not true. This time I'm telling the truth. So they came up with this about 15 years ago. And what it is, a device for people who have had heart attacks, their left ventricle is too weak to pump anymore, not sustainable with life. So what they did is this, they bore a hole into the left ventricle, put a tube in it, run the tube into a pump, increase the blood pressure, comes back out, puts it into the air. Good idea, right? It is a good idea, and it works extremely well. They call it left ventricular assist device, or an LVAD, that's what they call it. Here's the problem with it. It's a constant blood flow. Rotary engine, so it's running constant blood flow like a faucet or a hose. How's that a problem for you guys? There's no pulse. How do you take a blood pressure? You listen to it, you hear the pulse stop or start, and when you hear the pulse stop, there's no pulse. How do you get a blood pressure?
No.
How about pulse oximetry? How's that work? Because off the waves of blood flow through the finger and pulse, and it's a constant flow. How does that work? Doesn't. Then when you go to listen to lung sounds, all you can hear is a rotary engine go, oh. Kind of what it sounds like. Or an RX-7. Yeah.
So does the blood flow through the exercise? Blood flow.
Same amount of blood flow. Okay.
So sleeping or so.
Yep. It does, and you're still a cripple, you're cardiac cripple still.
So
But you live a better quality of life than not having it.
yeah. You know, like your lives or.
Well, your vasoconstriction, vasodilation still works, so just no one knows what your blood pressure is because it's constant flow. No,
That seems like it's not long.
they're more prevalent. You ever heard of Dick Cheney? He's a great guy to go hunting with. Was it? You walked in front of him? I don't know anything about it. I just know he's got a mind control camp in West Slopes, Mount Shasta. Most people don't know about it. Yes, I know, it's gotta be true. They've made millions selling books about it. But, the damn Merle Haggers. But, it's there, Google it. I'm disappointed I haven't come up with a story like that. But anyway, Dick Cheney lived like 2.5 years to know that before I got a transplant. So originally it was for bridge to transplant, then it was bridge to therapy, and now it's just bridge to end of life. They've lived with these things for a long time. Yeah, pretty much. Or how much money you don't have, then everything's covered.
The heart has four muscular pumping chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. The left ventricle pumps blood out through a large artery called the aorta to supply the body with the oxygen and nutrients it needs. In left-sided heart failure, the left ventricle is not able to pump enough blood to the body. The two types of left-handed heart failure are diastolic, where the left ventricle can't relax enough to fill with blood, and more commonly, systolic, where the left ventricle can't contract strongly enough to push blood to the body. In severe or end-stage heart failure, the heart is getting weaker and doesn't respond to medication. For left-sided end-stage systolic heart failure, a doctor may recommend an implantable left ventricular assist device, or LVAD, to help the heart pump enough blood to the body. An LVAD is a small mechanical pump implanted inside the chest or abdomen that takes over the job of the weak left ventricle. Blood flows from the left ventricle through an inflow tube to the pump. The pump pushes the blood through an outflow tube into the aorta. From
This is
here,
first
the blood
generation, they
travels
don't even have
normally
these
from the
anymore.
aorta to the rest of the body.
You'll be amazed at what they have now.
A cable called a driveline connects the LVAD pump inside the chest to a control unit located on the outside of the body. The control unit is a small computer that controls the functions of the pump and alerts the patient if there are any problems. The pump and control unit receive power through a cord connected to a battery pack. Finally, the control unit and battery pack are held in a lightweight patient pack. An LVAD may be a temporary treatment until a heart transplant can be performed. Or if the patient isn't able to have a heart transplant, an LVAD may be used for destination therapy, which is long-term treatment.
Here are the top 30 self-defense moves. Number 1, throwing dirt in your opponent's eyes. Throwing an object into your opponent's eyes is a very...
I've seen that on so many movies. All right, so central lines. I actually took a guy to Chico to get had a central line. Central lines are people that are getting medication regularly, like chemotherapy or long-term antibiotics, things like that. Or people that have no peripheral access, they keep them in there for critical care procedures. So they do is they're not like peripheral IVs like with paramedics where you can see the vein or palpate the vein, you just slide the needle into it and fly it over. They have to guess on these. So they go for landmarks, they just stick the needle in until they feel a pop somewhere deep inside the body. And they pull back to see if they get blood in the syringe. Then they have to run a catheter in, then they pull the needle out over the guide wire. They got to pull the needle out of the guide wire, then they slide the catheter over the guide wire into the vein, and then they pull the guide wire out so the catheter in place. Pretty tricky stuff. Here's a great example of putting one in. This won't be on the test, but it's good to know for you to see how they do it. So first of all, notice they have her Trendelenburg, feet in the air, head down. So all the blood fills the internal jugular vein. They're putting in an internal jugular central line here.
How to stop bleeding on this?
Central line?
Yeah.
Yeah. Cataracts. Cataracts plastic. Yeah. Actually, these are EMRs. The EMT's directing it. Got a great external jet. I don't know why to go for the internal. The external is fantastic. Electrodes fall off. I like the BSI of the girl holding the chin. Not like there's a chance for major blood to go flying everywhere. It's what? Betadine? Betadine? It's a disinfectant, antibacterial. Like something is on Paul.
Which is no good if somebody touches you.
That looks like alcohol after betadine. So betadine first, then alcohol.
क्या सर सेंटलाइन अक्सर नसीम सर बोलते थे करने के लिए लेकिन उसमें इंडिविजुअल में डर नहीं लगता इसमें पता नहीं क्यों अजीब लगता है
There she goes. Guessing. If you feel a pop, you can pull blood back. See how long that needle is, how deep she is in the neck? Go for number 3. Third try. Grass is wet. Oh, then she hit it. She hit it. Guide wire. Slide that guide wire in. Just pulls the needle out. Now it's just the guide wire. It's inside the internal jugular. Now it's going to feed a catheter over that guide wire. Catheter over the guide wire, all done. Questions? All right, gastrostomy tubes. These are people that have tracheas. This is how they eat. So they can't eat by normal ways. So they have to put a gastrostomy tube in. Now, you guys will see these when people pull them out. Yes, they will pull them out.
Your doctor may perform a percutaneous endoscopic gastrostomy, or PEG, to insert a feeding tube into your stomach.
if you are unable to take food by mouth for an extended period of time. Digestion of food begins in the mouth. When you swallow, food is pushed down into your esophagus, a muscular tube that carries food to your stomach where it is digested. From the stomach, food travels to your small intestine, where digestion continues and nutrients are absorbed into the bloodstream. Your doctor may require a PEG feeding tube if you cannot eat, digest, or absorb food due to esophageal cancer, oral surgery, or stroke, major surgery, trauma, burns, or anorexia, inflammation of the pancreas, or radiation therapy, or inflammatory bowel disease affecting the small intestine. Before the procedure, you'll receive a sedative through an IV to help you relax. A local anesthetic will be administered at the site on your abdomen where the PEG tube is to be placed. The most commonly used PEG placement procedure is the pull method. During this procedure, your doctor will insert a lighted endoscope through your mouth and thread it down your esophagus and into your stomach. A camera attached to the endoscope will produce images of the inside of your stomach, which will be displayed on a video monitor. Next, your doctor will insert a needle through your skin into your stomach at the location where the PEG tube is to be placed. While doing this, he or she will use the endoscope to locate the end of the needle inside your stomach and encircle it with a wire snare. Your doctor will then pass a thin wire through this needle into your stomach, attach the endoscope to the wire, and pull both the endoscope and wire out through your mouth. At this point, there will be a thin wire entering the front of your abdomen into your stomach and continuing upward and out of your mouth. Your doctor will attach the PEG feeding tube to the wire outside of your mouth. By gently tugging on the other end of the wire, he or she will pull the tube back through your mouth and esophagus and into your stomach. Your doctor will continue to pull until the tip of the tube comes out of the incisions in your stomach and abdomen. A soft round bumper attached to the portion of the tube that remains inside the stomach secures it in place. The outer portion of the tube will be secured with a bumper as well, and sterile gauze will be placed around the incision site. In the alternative push method, your doctor will begin in the same fashion by using an endoscope to guide a wire through your abdominal wall and into your stomach. But instead of pulling the PEG tube through your mouth, he or she will push it directly into your stomach over the wire. After your procedure, you will continue to receive fluids through an IV for 1 to 2 days. Once there is evidence that your digestive tract is functioning, you will receive clear liquids through the PEG tube. If clear liquids are tolerated, you will receive a tube feeding formula through the PEG tube.
I've never seen so much energy when it comes to feeding time because she just loses her mind ever since farm.
All right, Shunts, we touched on this a little bit. Is keep hydrocephalitis, keep pressure on the brain. It drains from the skull down into the peritoneum constantly. It works perfectly fine. They live perfectly normal lives until a shunt fails or gets flooded. Then we got big problems, and they get intracranial pressure quickly. A lot of times it's caused by shaken baby syndrome. Any questions?
Yes.
All right.
So in that like little sequence there, they drilled right into that guy's noggin, right?
Yep.
And it's like through the brain into that.
Not through the brain, just to the dura mater there, or wherever the fluid generated.
I was gonna say, cause that guy would probably have some sort of like defect from that.
And they just run it under the skin down into the peritoneum.
Okay, that makes more sense. The brain imagery kind of confused me a little bit.
Yeah.
We had a guy at my school, he worked in a hospital. I don't think we can put neck like this. Go flat.
But so you can get treatment in time.
Like a fan.
Uh-huh. He probably had a defect and didn't get treatment in time, so it grew that way. Once it grows that way, there's not a lot you can do. It's like kids that don't get the shunts put in, they end up with these giant, like they call them watermelon heads. These big oblong heads. It's pretty horrible. The next one is vagal nerve stimulators. These are used in a horrible disease called Parkinson's, which gives you uncontrollable shakes. And what does your vagal nerve is the nerve that runs your parasympathetic nervous system, which is all your vegetative functions. So what it does is it stimulates your vagal nerve, which stimulates the vegetative functions, which stops the shaking, which works really, really well. Who's the most famous Parkinson's patient out there?
Michael J. Fox.
Yep. And what is the link to him getting Parkinson's? No, it was plutonium on the set of Back to the Future. Direct link.
Why did they have plutonium?
What?
Why did they have plutonium back then?
That's what powered the flux capacitor.
I've never seen.
You've never seen Back to the Future.
What?
Yeah, in order for them to power the flux capacitor, they had to use plutonium, and that's what led to Michael J. Fox's, whatever you call this, Parkinson's. Thank you.
I see.
Yeah.
Brian, I have a question from the procedure before. So the X plus cerebral fluid goes into the belly,
Peritoneum, yeah.
and then
It just absorbs it.
And then the other, because the other version goes into the, there's another version that goes into the heart, the left atrium or something.
That one I don't know about. I know how it goes to the peritoneum.
It's shepherd's fluid into
Yeah, not as familiar as one that goes in the left atrium.
into the right atrium of the heart.
So it goes into the vena cava.
That's crazy.
Then your kidneys get rid of it.
Wow.
This is a vagal nerve stimulator. No, it's not. Psych. It needs that video anyway. All right, so choleostomies and ileostomies are common. These are people that have had to have colon surgeries or paraplegics, so they don't have the muscles to poop anymore, so they have to poop into a bag. There's a couple real important things. This is a great video, if it's still there, on the difference between choleostomy, ileostomies, and dehydration and how things work. It's gone too. Very good about it. She had a lot of passion. Yeah. Well, they sell that now. There she is. Right now, that's that chick from
You can feel
Psycho
it
Boyfriend.
when your dream becomes a pursuit. And with vitiligo,
Hey everyone, it's Sarah, registered nurse RN.com, and in this video, I'm going to be doing an in-text review over GI ostomies, specifically colostomies and ileostomies. And as always, in the YouTube.
Hi, my name is Joy Hoover, and I'm a certified wound osteopathologist. and I've invented a unique teaching tool to help explain various types of stoma surgery. Let me show it to you. With my anatomical apron, you're able to show the GI tract prior to the surgery. You're able to show changes introduced prior to surgery. Then you'll be able to show the probable location and the appearance of the stoma after the surgery. You'll be able to show.
So they do a ileostomy, they hold it together with Velcro.
Show how the doctor makes a small incision in the abdomen, takes the open end of the colon, pulls it through, folds it over, and sews it down. From surgical offices to hospitals to homes, my anatomical apron is easy to see, easy to use, easy to understand, and is machine washable. My anatomical apron can be used in elementary school to help explain simple digestion. In major.
That's the same lady. It's not?
I don't know why.
They would never let me design an apron.
Hi, my name is Laura Cox, and I'm Field Healthcare's Acme Lifestyle Specialist. Today, I have the pleasure of introducing you to Joy Hooper. Joy is a CWOCN, OMS, and WCC. She is also the creator of the anatomical apron. Today, she's going to be showing us a few positions.
First, let me explain how the food travels through the GI tract. We chew our food and it goes down our esophagus and into our stomach. When it gets in the stomach, it's held, it's churned, and then it's slowly released to go into the small intestine. Now, as the chewed up food is going into the small intestine, the pancreas, the gallbladder, the liver, all add in additional digestive enzymes to help break that food down, that steak, those greens. They just get pulverized with those digestive enzymes, as well as that muscular action, moving that chewed up food through the GI tract. Now, as it's getting pulverized, the walls of the small intestine are absorbing those vitamins and nutrients and taking it to use for fuel for our bodies. So it's like the small intestine eats for us. All right, so after the food has traveled through the small intestine, it's going to go into the large intestine. And your large intestine, or your colon, it drinks for us. Because as that chewed up food is traveling around through the colon, it's reabsorbing that liquid through it. So it gets thicker and thicker and thicker with the more colon that you've got. So it finally exits our body out of our anus. Now, a common ostomy procedure is the colostomy. And to do a colostomy, what the surgeon is going to do is separate the colon just like that. Now, if it's a low rectal cancer or an anal cancer, they may need to even remove the rectum or the anus and close that part of the body up. But if they don't, they're going to leave it intact, and this is going to be known as the Hartman's pouch. Now, getting back to the colostomy, surgeon's got to do something because you've got food going in here and still coming out here. So what the surgeon will do is make a small incision in the front of the abdomen, take the open end of the GI tract, pull it through, fold it over, and create what's known as the stoma. And this is where the person's stool is going to exit their body, and they're going to wear a pouch over it to collect that stool. So that is a colostomy. Now, the next diversion I want to explain is called an ileostomy, because it's going to occur in the ileum section, the final section of the small intestine. And with this procedure, what the surgeon does is separate the small intestine from the large intestine. And then they're going to do that same stoma procedure where they make the small incision in the front of the abdomen, take the open end of the GI tract, pull it through, and create that stoma. Now you notice with this one, the stoma is smaller with that. And that's because the diameter of the small intestine is so much smaller than the colon. Now, a couple things that you want to notice with this stoma right here. Notice that this is coming right off of the small intestine. You remember those digestive enzymes we talked about, breaking that steak down and those greens? Well, when those digestive enzymes get here on the skin, all they know how to do is digest. And so when they're on the skin, they are digesting that skin. Another thing that's important with the ileostomy, the person doesn't have a colon drinking for them anymore. The colon was either removed or closed up, so they don't have that colon drinking for them. And what's going to happen is their stomach and small intestine have to pick up the slack. for drinking that, drinking for the body. So what we need that person with an ileostomy to do is drink extra liquids to avoid dehydration. But that is an ileostomy. Now, the next version that I want to show is actually going to be a form of either the colostomy or the ileostomy. It's just a different way of doing it, okay? Because with the stomas that I showed before, what we used was the end of the GI tract and we folded it over like a cuff to create that stoma. But what you're going to see with a loop stoma, what the surgeon is going to do is pull a loop of the GI tract out through the abdominal wall, similar to this, just like this, and then to keep it out there, what the surgeon is going to do is use some type of stabilization rod to hold it in place. Sometimes they use a catheter, but something to hold this in place and keep that loop from sliding back into the body. Now, let me show you with this piece right here what's happening. So they pull this loop of the GI tract through, put the rod behind it, and the way that they open it up is the surgeon's going to split it across the top and fold it back. Now, notice what happens if I were to split this and then fold it back. You're going to have a stoma that has openings going into either side of the GI tract, because remember, I just pulled a loop of it through. Well, sometimes the stomas can look like this, or sometimes they can come out a little bit more and look like two stomas side by side, or even sometimes they look like that. So a loop stoma can appear many different ways. It's just important to know that it's got two different openings right there. It's still a great functioning stoma, just like the end stoma is. Now back to this rod. Remember, the rod was put in place to keep that loop of GI tract from slipping back into the abdomen. Well, after about 7.
Any questions? Some of these are good videos. You guys want to watch how left ventricular assist device is poured into a left ventricle?
Yeah.
Caution, the hardware ventricle.
Huh?
What kind of calls do they show? What happens? They have calls. What the colonoscopy?
Very rare. Usually it's something you just need to be aware of when you find it. And understand what it's there for.
Right.
Sometimes bleeding into it, it's never good. Blood in the clots too bad, it's very bad. We had those before. So this is the new generation of LVADs. So instead of doing like the one in the video you saw before, they just plug this straight into the ventricle. It goes into the pump and then goes straight to the atrium, the aorta.
Versus system is a miniaturized for the treatment of advanced heart failure. At the core of the hardware platform is a proprietary suspension system for the wide-bladed impeller. Using a combination of both hydrodynamic and passive magnetic forces, a thin layer of blood is established between the impeller and the pump housing. During operation, there are no. Its small size and integrated inflow cannula allow the device to be implanted completely in the pericardial space, directly at.
Way cooler.
I can enjoy a beautiful day like this.
Oh, they took away the one that they were putting it in. Wait, maybe. Yeah, here we go.
In this video, we would like to review the surgical aspect extending into the abdomen to the level of approximately halfway between the xiphoid and the umbilicus. Prior to sternotomy, the subrectus LVAD pocket is created in the left upper quadrant. This is performed by elevating the rectus muscle away from the posterior rectus sheath. Care is taken to cauterize or clip all muscle perforating vessel in this area to make sure that the pocket is hemostatic. Similarly, dissection is performed on the right side, although not as extensive, to make sure that the LVAD will fit appropriately into the pocket. After heparinization, routine arterial cannulation is performed in the distal ascending aorta. Venous cannulation usually can be achieved with a single venous cannula in the right atrium. If closure of a PFO is required, as in this patient, then bicable cannulation is used. The diaphragmatic muscle attachment from the left costal margin are taken down. Care is taken to ensure meticulous hemostasis during this maneuver, as this area is prone to bleeding. The LVAD model can be used to assess the proper fit in the LVAD pocket. Implantation of the LVAD can be performed on cardiopulmonary bypass with the heart beating. The aortic crossline with cardioplegic arrest is usually not necessary. For this particular patient, a PFO was identified. After cardiopulmonary bypass was initiated, we elected to arrest the heart for the PFO closure.
Pours it right in there.
The right atrium was open and the PFO closed primarily.
Yeah. Too much fats on that heart.
Yeah, that's my neck.
Is that normal or is that?
The right atrium
Americans
closed.
abnormal.
Crossline released.
Not around here, no. Guarantee you mine looks like that.
The left ventricular apical cannulation site is identified for the LVAD inflow canal. The site chosen is slightly lateral to the left anterior descending artery and slightly anterior to the
There,
LV.
he pours it
apex.
out right there.
The coring knife is used to remove the LV apical cord. Care is taken to properly orient the coring knife parallel to the interventricular septum. Once the apical cord is excised, inspect the LV cavity for thrombus and trabeculae that may impede proper positioning of the LVAD inflow cannula. Approximately 12 to 16 horizontal mattress, full muscle thickness 2O, felt pleated polyester sutures are placed circumferentially around the apical cord. At our institution, we favor placing an additional inner felt strip around the apex to allow for greater cushioning and reinforcement of these horizontal mattress sutures. The suture are passed through the LVAD inflow conduit.
I was just run a puppet show, the marionette.
The inflow conduit is lower and tied. The inner ring of the LVAD inflow conduit is removed with this. The LVAD is brought up to the field and inserted into the left ventricle. Care is taken to make certain that the LVAD inflow cannula is flush with the conduit.
Yeah. This is like Dick Cheney stuff.
Inflow conduit suture is tied.
Hospice. It's critically important you guys understand what hospice is and how to work with hospice. So hospice, the concept of hospice is people that are not going to get better, that are chronically ill. 30 years ago, we did CPR on everyone. If you were 102 years old and had your body riddled with cancer, we were at a full code on you. CPRs, medications, everything. And we don't do that anymore. Now we try to give people a dignified quality of death. We figured out we were giving our pets a better quality of death than we were giving our loved ones. So now what we do is if people have decided they don't want to have heroic measures taken, and they know they're going to die, that they're chronically and terminally ill, they can choose hospice and get comfort measures and comfort medications instead of heroic life-saving procedures and life-saving medications. Now, that said, these people should never have 911 activated. And if the hospice people, the hospice doctor do their jobs correctly, do the proper counseling, they will never call 911 and you'll never interface with it. However, we are far from a perfect world. And so you'll actually be interfacing with it quite often because you can't control what other people do. So, family members that are not on the plan, haven't had the counseling, haven't had the education. They're there, they see Granny struggling to breathe, what are they gonna do? Exactly, even though 911's not supposed to be called, it's just called a hospice nurse. So if you get there and you find out they're in hospice, you have to let them know, they should be contacting their hospice nurse for direction. That you're more than happy to take them to the hospital, but if you do, they're going to lose their hospice benefits, because that puts them back into the regular system. You have to give that information. And preferably contact the hospice nurse while you're there to make sure they get contact. But sometimes the hospice nurse will say, yes, please transport it if there's a reason to do it. But that's pretty rare. Any questions about what hospice is and how to interface? Well, I said, Katie first. For instance, let's say it's someone that's dying of lung cancer, and they're doing hospice at home with another elderly caregiver, and they've fallen and broken their hip. That might be able to just be a simple hitting of the hip. They might have to be taking them for a quick pin of the hip or something, so that they don't have to go to a step. They can still be taken care of at home, which will cost as much for hospice. That would be an example, or a broken arm.
What are the hospice benefits?
Hospice benefits are the counseling, the nurses that are talked to, usually it's high dose opiates, narcotics, and benzodiazepines, anti-anxiety meds. So when they get having real troubles breathing or severe pain and cancer, they give them the high dose painkillers and the anti-anxieties, just keep them calm and keep them relaxed as the process takes its toll. Still not a pleasant thing to watch, especially for that. That's the other door you're gonna run into is the family's on board for hospice till right to the very end. Then they can't do it at the end, and they call 911. Then you got a situation. Usually the hospice nurse will come over and take over, take charge and make arrangements. Any questions? Okay, back. Poverty and homeless. This is a huge part of the 911 system. And it has gotten even more part of it. Anybody watch this Philadelphia cameras I put up? There are 5 to 6 medicals a day on that camera. Full-blown medicals. There's unique challenges associated with homelessness and low socioeconomic situations. So a couple things. One, the 911 system is their only access to support for anything. For a ride, for a warm meal, to get out of a bad situation, to get out of the weather. And they will say anything they can to do that. That frustrates a lot of EMS people. But it is a factor and part of the system. So you need to get used to it because there is no better way of doing it. The other side of that is these people also live in the worst conditions and have the highest amount of medical problems because of the low socioeconomic things they're forced to live in, that many of them don't have a choice. So they have a greater chance of being sick from things than people that live in nice, warm, dry houses with plumbing and running water. Does that make sense? So just because someone has been called 25 times, and this is the 26th time you picked out, doesn't mean that this time it's not the life-threatening emergency, because eventually it's going to be. Any questions? Let's see what you guys have learned. You're a dispatch command of general weakness. What do we do first? Your BSI is on. You're seeing a typical family dwelling. Patient states he's too weak to walk. That's a good chief complaint. What do we do next after seeing size up? Patient mid-70s male appears very ill. He's alert. His chief complaint is he's too weak to walk. Airway is clear. He's breathing adequately. You may or may not order O2. You're unable to palpate a radial pulse and you're unable to palpate a carotid pulse. However, the patient is alert. The skin signs are ashy, warm, and moist. What comes next? History. Signs, symptoms, weakness provoked this afternoon after eating, severe weakness, quality not radiated. It's severe in the timeline's been about 3 hours consistently. He has no drug allergies. He's got a whole shoebox full of medications. Vascular history of severe heart failure and renal failure. Last meal was lunch. He's been able to walk since lunch. What's next? All right. You're unable to palpate a BP or a pulse. Patient's respiration 16, not labor. He's got a Glasgow 15. He's wearing a vest with batteries and tubes that go into his chest. And you try to listen to lung sounds, but you can't hear him over a machine in his vest. It's going. Any questions? What is this? An LVAD patient. So that's actually changed. They have you do CPR now. It depends on what your local protocols are. Know your local protocols. CPR is not going to be effective. Yeah. Used to be you don't do CPR, now you do. And then their ventricular fibrillation, you absolutely shock them. This is an assist device. It's not a mechanical heart. Cannot pump blood if the heart's not pumping blood. If the right ventricle is not sending blood to the lungs and back to left atrium, this does not work. Any questions? Yes.
Do you turn the machine off to shock them?
No. Let her run. Because actually the machine's on the outside, it's not on the inside. Just the pump, the control unit is on the outside. Yeah. Any questions? They should have a companion. Bring the companion with you. Yes, sir.
So I guess the only difference is whether or not they lose consciousness.
Yeah, so what happens if they lose consciousness, they're not breathing? How do you know if they're dead or not? How do you know? Right, they could still be alive and just be unconscious and not breathing. What tool would you have to know if they're still alive? You guys have it. What monitor? So would you put an eye gel in them? Why? No.
Gag reflex.
So they don't have a gag reflex. Would you put an eye gel in them? How do you confirm the position of an eye gel? And what else? Chest what? Rise of all, what else? Yeah, colorimetric. If they're exhaling carbon dioxide, they're alive. If they're not exhaling carbon dioxide, they're dead. Because carbon dioxide exhalation is from cellular life. That's how you tell. So let's say they got a gag reflex. What do? You BVM them and you hook the color matrix between the mask and the BVM. That's how you know. Any questions? All righty. Why don't you boys and girls go to break? Come back about 5 minutes after 5 minutes to 8. Come back at 8 o'clock.